morning, everyone. For those who don't know me, my name is Pascal Amate. I'm the director here at UNUIIGH, United Nations University International Institute for Global Health. Welcome, a very, very warm welcome to, I think, our first seminar this year. Is that correct? First? Second. What was the first one?
The first one was by Joanne.
Oh, okay, I was here. Okay, sorry, the first one that I have attended this year. We are very privileged to have two eminent speakers from the UK, Dr. Austen El-Osta and Dr. David Weber from Imperial College London. I met Austen last year at a meeting at Wilton Park in the UK as part of a growing area of work with the WHO, which is growing. WHO always rehashes these old things and calls them new things. Putting a focus now on, or increasing the focus now on self-care. The idea being that there's so much technology now that allows us to take control of our own healthcare services. Part of that is aided through digital technologies. Part of that is, you can do your own cervical cancer swab and send it in. You can do your own diagnostics for HIV. There's a whole range of things now that are possible. And from the WHO's perspective, the question is, how do we make sure that these are a part of a health system? How do you give individuals control and still make sure that you can continue to have a seamless link to your health system, but at the same time you don't escalate the cost by doubling all of these. So there are a range of perspectives on this, and we have these two wonderful speakers who are going to talk to us about it. From UNUIIGH's perspective, we need to think about this from a global health perspective. We need to think about this within the context of how we make health systems seamless regardless of borders. From a national Malaysian perspective, it is about thinking about how this is relevant for the Malaysian health system. So I hope that regardless of where you're from, you will take something important away from this. And I will stop yabbering and hand over to Austen. Thank you.
Thanks again, Pascal, for the invitation, and thank you, Professor Anwar, and it was great to see CRPS today. And again, special thanks to Burani for making this visit possible, and Professor David Weber, who has been a fantastic ally in this healthcare space, that you will follow in the next talk. So very briefly, I'll try to give this talk in 30 minutes. Self-care for 21st century living, and this is how we're going to do this. Quickly discuss the aging trends in the 21st century. We're going to define self-care, think of ways of conceptualizing it. We want to consider how self-care can combat non-communicable diseases that we are burdened with today, and to have a look at some of the evidence behind self-care interventions, and then conclude with a review of potential avenues for R&D in the self-care space. So hopefully we all want to live long, happy, healthy lives. And biological aging is normally when we get older, we sag and we wrinkle, and then we may become frail. But oftentimes today we find aging is coupled to non-communicable diseases, obesity, type 2 diabetes mellitus, and of course as cardiovascular disease and polypharma. And in this example, we have someone whose toe has been amputated. So again, we remember that there's a biomedical model that we've been using for a while, which really defines our healthcare system today. And this model assumes that diseases come from the outside, that we should focus on treatment as opposed to prevention. Treatment is usually with vaccines and medicines and surgery, and that the medical profession is, for a while now, has been solely responsible for getting us better. There is, however, a move to have more a person-centered approach to medicine, and we can review that later. But all of this means that patients usually play a passive role, and they're not really encouraged in self-care. This conflicts then with the holistic model that we had many thousands of years ago. But there is a recognition from very prominent physicians, including Mayo, the Mayo Clinic, says that the aim of medicine is to prevent disease altogether, and the ideal of medicine is to eliminate the need of the physician. So this is an interesting thing to remember. And health systems worldwide are now getting ready to drive care out of the secondary care setting, out of hospitals, into the primary care and the community care setting, ultimately into the home, back to the person, the individual. And this is supported by a wide push to get some policy drivers. This is an example from the UK, but if you look at Malaysia or elsewhere, there would be some examples of policies. Certainly WHO has this thinking. The idea is we don't want passive individuals who don't care or who aren't given responsibility for their health. Ideally, we will empower individuals to become active agents, to take more control and ownership of their health and well-being. And the idea is to, therefore, live a longer, healthier life and cost less money. And to focus more on upstream measures of prevention than on downstream measures of intervention. This is because we spend most of our time outside of the clinical care setting. So this box here shows 8,760 hours in the year, and we spend less than an hour normally with a medical professional. So what are we doing at all other times? We're self-caring, whether we like it or not. Just to remember then, the 1978 first international conference on primary healthcare in El-Osta, which led to the El-Osta Declaration. And if you look at this declaration, which was very important at the time, still is, and all health systems worldwide aspire to achieve its tenets, you can see here highlighted in blue that there are fingers pointing to what is essentially self-care. The person, the people have the right to and duty to participate individually in the planning and implementation of their healthcare, self-reliance, participation, etc. So what is self-care then? Put simply, self-care is a practical, person-centered set of actions that we should all be doing to maintain our health, wellness, and well-being. Through self-care, people can be healthier and remain so into old age, and they can manage minor and common conditions themselves. And self-care, as we'll see in a minute, can actually prevent or delay NCDs. So not only is self-care important internationally, in Malaysia, but it's important to each one of us. The WHO has been doing a lot of work in this space, and our meeting in September was an example of the refreshed interest in the self-care space. The WHO has a number of definitions for self-care. Here are some examples from 1983 to 2009, and as definitions expanded, they became more inclusive to include elements like health and well-being. So there is a direct link between self-care, health, wellness, and well-being, and here are descriptions of each. But we can see here that we can actually measure or quantify health and lifestyle by measuring things, but the idea of wellness and well-being is more subjective and more quality related. So self-care is a set of actions, but it's also an ongoing process. It's performed in both healthy and ill states, in which case we call it self-management. And we know there are so many definitions. So a recent paper in 2011 showed at least 139 definitions of self-care. What we want to share with you is the idea that self-care is comprehensive. It means many things, and we'll come to that. But written definitions are awkward and distracting. A better way of looking at it is to try and conceptualize it visually. I'll give you 3 examples. In this example, you may be familiar with the illness-wellness continuum. Here on the left, with a score of 0, people who aren't happy, who are diseased, who have poor health, and a scale of 10, optimum health, wellness. So on the left, then, you can imagine the individual may have very little capacity or capability to self-care. On the right, they will probably be enjoying the potential for self-care on a regular basis. So here, as a second way of conceptualizing it, is to consider the self-care continuum. On the left, you have healthy behaviors, which hopefully, like us, you're applying day after day. If you break your leg on a skiing trip, you would need nurse support, and then eventually you hope to recover and regain that healthy behavior and make your own lifestyle choices. But people with long-term conditions would probably be along the middle of the continuum. So again, if you look at this slide on top, you have pure self-care, what we're doing every day. On the occasion that we have a cold or a we're about infection, we will self-treat in collaboration with our medical professionals. And with people with long-term conditions, for example, diabetes, they would need self-management for these conditions. And unfortunately, someone may become incapacitated if they have an accident, and they cannot self-care. So at the very bottom of the slide, you see here that there's a prevention idea. We should try and keep disease away from us where possible, and manage any conditions that we have, as opposed to just think of interventions. The third way of conceptualizing self-care was developed by David Weber and the International Self-Care Foundation. And this is a visual depiction of the 7 pillars of self-care, which show you that we bracket activities into 7 main pillars. First being knowledge and health literacy, that allows you to make appropriate decisions. The second being mental health, self-awareness and agency. For example, knowing your BMI, knowing what's good for you, knowing your blood pressure, if possible, and other things. The third and fourth pillar are obvious physical activity, healthy eating. And then we have pillar 5, risk avoidance, and this can come in many forms. But really, it's the remit of public health here, reducing smoking, reducing alcohol, but also putting on a seatbelt. And in the modern context, digital hygiene, trying to limit the amount of light you get from your phone before bedtime. And pillar 7 is the rational use of products and resources, including over-the-counter medicines and services and assets. So here then we can begin to see a model of sorts. We have the 7 pillars of self-care, and depending on how you do your self-care, you end up on a continuum of care. The missing link, of course, is behavior change. So not only do you need to know something, you need to actually have some behaviors that are sustained in order to control where you are on this continuum. Now, there are at least 83 theories of behavior change, and this is one example. The behavior change wheel model developed by Susan Mitchie at UCL in London basically says that for behavior change to succeed, the individual needs to change one or more of the sources of behavior, which are capability, opportunity, and motivation. But it doesn't matter which way you look at it, getting people to change behavior is actually quite difficult, especially at our young age. Once we've made up our mind, it's difficult to change. And we hear a lot about technologies and applications, that vibrate and send you nudges, but oftentimes, as we hear, these are supplier-led. New technologies developed and they sell it to people. We need more patient-public engagement. We need more demand-side interventions. And we've seen a huge explosion, essentially, of what are called self-care apps. But getting nudges and gamification is one thing, getting sustained behavior change is another, and there's a lot of research happening in this space. The second bit now, the link between self-care and non-communicable diseases. So chronic diseases account for more than 70% of all deaths globally. And if you look here at this simple diagram, 36% of deaths are cardiovascular related. Diabetes is a huge burden, and there are other chronic diseases, lung disease, etc., and cancers. So 70% plus of these diseases actually have a direct link to how well you can self-care or self-manage, and potentially can be prevented. So the global burden of NCDs is huge, we know this, and they are society's major threat. At the same time, people are living longer and suffering the comorbidities, and there are financial consequences of this. And a third of people with NCDs die prematurely between the age of 35 and 69, and 80% of these premature deaths happen in low and middle-income countries. We also know from evidence that there are many risk factors that lead to chronic disease and NCDs. Globalization, urbanization, people living in compact cities with pollution. Personal risk factors include unhealthy diet, physical inactivity, use of tobacco and alcohol, and to a lesser extent our genes as we age. It's become more relevant. Intermediate risk factors, and here I put these in red because they're important: raised blood pressure, raised glucose, abnormal dyslipidemia, and increased BMI, which lead then to the chronic disease that we discussed. In the context of Malaysia, this is a graph of a 2010 study, the burden of disease attributable to 15 leading risk factors in Malaysia, and almost all of these risk factors relate in some way to self-care and healthy lifestyles and mirror what we've just seen. But when you do get a condition, this sort of depicts that nearly 50% of your capacity and capability to get better actually relates to how much you can and are able to self-care. Of course, healthcare input is important, medicines are important, interventions are crucial, but your biology is much less important, and your environment also only contributes 10%. So your capacity and capability to self-care is phenomenally important. And self-care has many conditioning factors, obviously demography, where you live, your age, ethnicity and race, the way you perceive health, and who should help and who shouldn't, your social network, and many other conditioning factors. And again, in the context of Malaysia, we may want to consider to what extent is universal health access helping people in rural communities compared to capitals. I mean, this is not just in Malaysia, elsewhere. Other things for consideration is the workforce that you have. How can you support the workforce to help people become more enabled to care for themselves? And the risk factors, and David will tell us more about that. We've noticed that you don't have much of an alcohol problem, but these are specific to Malaysia. But these are all opportunities to do some work in the self-care space. So we know then that more than 80% of heart diseases, diabetes, and strokes could be prevented by eliminating shared risk factors. This is from the WHO. So if we eliminate these tobacco use, unhealthy diet, physical activity, and reduce the use of alcohol, we may prevent, delay, or even prevent these NCDs. And the global epidemic of long-term non-communicable diseases we see today is a direct result of our inability to self-care. So what is the evidence behind all of this? So more than a third of all deaths can be attributed to the following 5 risk factors: elevated levels of blood glucose, tobacco use, physical inactivity, obesity, and high blood pressure. And all of these risk factors are modifiable through the adoption of healthy lifestyles and behaviors. So this is very empowering. And systematic reviews in 2009 and 2012 showed that positive health behaviors and ongoing self-care activities have the potential to do 2 things. 1, reduce all-cause mortality, and 2, prevent up to 93% of new onset diabetes, 81% of heart attacks, 50% of stroke cases, 36% of cancers. The quality of life implications of this are phenomenal, and the financial implications are huge. So this is a very important piece of work, and we need more RCTs and more studies to actually tell us more about that. Here's another example of a King's Fund study looking at more than 550 systematic reviews, meta-analysis essentially. It shows that self-care greatly improves quality of life, and activated patients, or these patients who want to get better because they want to learn how to self-manage, also utilize less resources and are long-term healthy lives. The financial analysis of self-care, again, there are a number of studies that look at this. Cut a long story short, if you invest in self-care, you will get a return on investment. Now the number changes, but it's always positive, it's always more than 1. So an evaluation of a program in England, for example, showed that if you self-care, you reduce the need to GP appointments, A&E admissions go down, you have a good return on investment, and you can generate quality of life benefits. And it doesn't matter which way you cut it, or what study you look at. People who stay out of hospital, outpatients, or who live in the community, who self-manage, cost much less money. So self-care as a foundation of health is largely outside the formal healthcare system. So this is how we see it. You spend most of your time on your own. There's primary care, secondary care, tertiary care, but it's inversely related to cost. And actually, in real terms, the last pyramid on the right shows you that, in fact, if you really want to do this properly, you won't even see the green line, because you have very little cost implications for self-care on a daily basis. Everybody benefits from self-care. We won't go through this, but it's clear that how people, governments, professionals, and industry benefit. And to conclude, I just want to give you an idea of what sort of work we're doing in the self-care space in terms of research. So some years ago, I had the pleasure of meeting David and our other partner, Pete Smith, from the Self-Care Forum UK, and together we collaborated to formed the Self-Care Academic Research Unit. This is based at Imperial College London, and our work, although we call it academic, we're doing a lot of applied research. So our vision is to be the leading academic base for self-care, and our mission is to make the absolute case for self-care. And by that we mean look at cost-effective analysis, and that may take a long time to do studies like this. And we are very keen and delighted to be here to meet the stakeholders and to share some of our learning with them. So our program and activity is based around 7 main bits. We want to synthesize evidence in relation to various aspects of self-care. We want to evaluate self-care interventions, because in so doing we learn about what works and what doesn't. We want to work with industry, sponsors of device manufacturers, wearable tech, IT, etc. We want to explore how self-care can benefit the wider health economy, and do some analysis as regards from the perspective of funding of outcomes as opposed to activities. A lot of the healthcare systems, certainly in the UK, hospitals are paid by the activities they do. They're not paid by how well have you been able to improve the quality of life of the patient. We want to establish and maintain a database and repository of evidence for self-care interventions. And I know some people here are interested in self-care and mental health theme, so that's also very important to us. And we would be very interested to consider how policy can drive all of this. Now, we have been doing some work, but I just want to share with you the 2 key outputs that we're bringing to you in the near future. The first output is the self-care matrix, which is a new model that anybody can use to try and grapple with self-care. And the second is a toolkit that we hope would be meaningful to stakeholders. The self-care matrix basically builds upon the model that we showed you earlier. It says that self-care has 4 dimensions. Self-care activities, which we've described as being the pillars of self-care. The second dimension being behavior change, and that's very important to sustain that. And then, depending on how you do in mode 1 or 2, you end up in self-care context, or essentially resource utilization. Commissioners are very interested in the 3rd dimension, and they normally look at that only. But this model shows that you need to, if you want to change where you are on the continuum, you need to look at dimensions 1 and 2. And again, the 4th dimension is the self-care environment, policy, fiscal policy, and all, etc. And interventions can then be planned for either dimension, and you can imagine here how perspectives will differ. With dimension 1 being at the micro or person-centered level, dimension 2 is more social network focused, the 3rd dimension is operating at the patient-centered level, and the 4th dimension is at the macro level. The second output is the toolkit, which has 5 tabs. Basically, tab 1, this is going to be a website, orients people around self-care generally, gives them very basic understanding as we have shared with you. The second tab is really some pointers and guides for people or stakeholders who want to develop self-care interventions. What should you consider when you're developing a self-care intervention? The 3rd tab is for commissioners. If you're going to pay for something, if you're going to pay for initiative, what are the quality elements you should look for specifically to assure that this is a self-care intervention that is somehow going to work? And then the 4th tab looks at evaluating self-care interventions and ideally how to report them. And the 5th tab is some shared examples. Briefly, there's a lot of talk about social prescribing, there's a lot of talk about personalized medicine, a lot of talk about schooling and to ensure vitality and aging, and how we can instill a culture of self-care at a very young age, and how the role of the pharmacy can actually change over time to enable self-care in the community setting, potentially by using more point-of-care testing. Pascal alluded to this, and how, for example, they may be able to offer potential diagnosis and bring out the best in people to care for themselves. Briefly to mention, workplace health promotion is also very important. We spend most of our life either asleep or at work. So when we were asleep, there's not much we can do about that, but when we were at work, our employers have a responsibility to give us the tools we need to care for ourselves, essentially self-care. And there's a lot of talk about self-care in this space. There are many entry points to self-care, and we can imagine that we can design so many interventions with a self-care theme. And just to remind us about the best buys and recommended interventions for self-care generally, I mean, limiting tobacco use, reducing harmful use of alcohol, limiting unhealthy diet, physical inactivity is a big problem, preventing CBD and diabetes, and focusing on chronic respiratory disease, trying to prevent COPD, for example, and the early detection of cancer are WHO's best buys and recommended interventions. So we need to think of a similar menu for self-care interventions. But I think these speak very closely to what we've discussed. We've heard about this, the health in all policy. This is governments are very interested in that now. And the ISF, as you'll hear later, are doing a lot of work with green spaces and trying to, if you're going to engineer a new town, what aspects should you consider to ensure health in all policy? Why not then have a self-care in all health policy? And by extension, why not have a self-care in all policy? Self-care then will shape the future of society in the context of 21st century living. But culture and society are very slow to change. There is a global movement for self-care. We had a World Park dialogue, and I'm pleased to have met Pascal there. The Alma Ata Declaration was reviewed in October, and there was discussion about making self-care a central pillar of primary healthcare systems. In England, we had the prevention strategy published recently, and the WHO have said that they will be releasing some self-care guidelines for sexual health and reproductive rights in the near future. The British Medical Journal are going to be publishing a special supplement on self-care, and as we'll hear again from David, the International Self-Care Day has been happening 24/7, 24th of July every year, and we invite Malaysia to consider doing something to commemorate that day. So to summarize and conclude, there is a revolution taking place. Self-care is obviously very important. We do need a global champion, and WHO has risen to that occasion. And this is a major opportunity to promote public dialogue in this space, and we're really pleased to be here and to share some of our thinking with you. Thank you very much. So I'll be happy to
Thank you very much indeed to Pascal for the invitation, the opportunity to talk to you today. It's a real pleasure to be here, and a pleasure to be back in Malaysia after my single previous trip, which was exactly 10 years ago. And things have changed quite a bit. Many things for the better, certainly. I'm delighted to follow Austen's wonderful presentation, which really covered many of the elements about what is self-care, why is it so important, and I wouldn't want to start without underlining the huge potential opportunity that's described there. The idea that 80% of cardiovascular disease and more than a third of cancers could be prevented, not just delayed, although that's an aspect to it, could be prevented if everybody self-cared perfectly. That's a huge potential opportunity. So in a way, the question becomes, why doesn't that happen? What has been the barrier? What has been the challenges? And one of the challenges certainly is embedded in the challenge of behavior. It can be quite hard, it can be very hard to self-care to the extent that one needs to do. We'll come back to that in a minute. The other element to it is what I'll say a little bit more about. And my presentation focuses on giving some examples, more examples of self-care around the world, and I can only pick a few of the many types of things that are happening around the world to give a flavour of the push there. So I'll talk about different examples around the world, and importantly, how there are many different stakeholders in self-care. And lastly, that leads on to questions of policy, questions of where we go now, where Malaysia might wish to go with this. So that's towards the end. Just by way of brief introduction, ISF is an international charity based in London, with the only global charity that focuses on the whole of self-care and on the self-care itself. I mean, many charities focus on some aspect of self-care, healthy lifestyles, healthy activity, nutrition, whatever, but we focus on the totality of it. And we do essentially two things. One is around promoting the role of self-care in health with various devices, which I'll illustrate. And the second is supporting and encouraging academic research, because self-care has been somewhat neglected by academia in the past, because it largely exists outside of health systems and even outside of social care systems. And that's one reason I think it has been neglected by academia, and that happily is now changing. So let me say a little bit about, first of all, about self-care stakeholders. And I think this is a really important slide in the sense of showing that there are many different stakeholders, all with slightly different agendas. And in fact, what's happening, what happens today is that there are many, you could say, silos of activity. Wonderful things are happening related to self-care all over in different places, but they're not connected up. They're not even using the same terminology quite often, but actually it's all self-care that we're talking about. So a key challenge and a key reason self-care hasn't taken off to the extent that it could have done is effectively the existence of silos of activity that need positively to be joined up. And this slide also illustrates the fact that, the important fact that here we've got at a global leadership, international level, we have fantastic global leadership from the UN itself, given the economic importance of NCDs, and from the WHO. Fundamentally, though, of course, self-care needs to be promoted at the country level, and we have many different stakeholders at the country level. And at the end of the day, it's all related to the self-care of the person doing something differently, perhaps. I think is the challenge. I think you'll all be very familiar with many of the elements from the UN and the WHO. Back in 2011, the UN General Assembly looking at NCDs and producing a declaration with a number of very important observations, including things like recognizing that prevention must be the cornerstone of the global response to NCDs. And how do you achieve prevention? That is people changing their behaviors. That is actually self-care, of course, that's being talked about there. And since then, we've had second and third high-level meetings on NCDs, which is reinforcing the prevention message. The SDGs themselves, Goal 3, of course, ensure healthy lives and well-being for all at all ages, is the same message. WHO, as we've heard from Austen already, has described healthcare on a number of different occasions, defined and described. And there are many, many different work programs that are important and relevant to self-care. Action plan on prevention and control of NCDs, lists self-care related activities, reduction of insufficient physical activity, reduction of salt intake, etc. These are describing self-care behaviors. And importantly, the WHO Department of Public Health, Environmental and Social Determinants of Health. So I'll come on to in a minute. The social situation in which that we all live is extremely important in encouraging or discouraging self-care. I won't go through more of the WHO aspect, but there are tools produced by the WHO which are important, and Austen has mentioned already the best by examples of interventions which are also relevant. But fundamentally, of course, the WHO operating at an international level can't get so involved with the details of how to achieve targets at a country level, or how to deliver prevention at a detailed or individual level. Country level is key. And this is one of the challenges. The UN and WHO tend to use the term prevention more than the term self-care. And as we'll see, different stakeholders tend to use slightly different terms, even though they mean the same thing. And of course, the WHO has a health system, medically oriented, disease-focused orientation, which needs to be connected up with the individualistic, individual agenda. And a set of guidelines that they were trying to produce in 2013 were abandoned through lack of academic evidence, and this is now being revisited in a smaller way. And This is back to the 2011 political declaration. But I think it illustrates really the challenge. In effect, we have, to start with, high-level political support and also a recognition of the complexities involved. It's worth just reading this through. Recognise that effective NCD prevention and control requires leadership and multi-sectoral approaches to health at the government level, including, as appropriate, health in all policies and whole of government approaches across such sectors as health, education, agriculture, sports, transport, communication, etc. It's making a very clear point there that there's so many different silos, so many different agendas that are relevant to self-care, and bringing these together is going to be a particular challenge. We have a very good model, of course, for one set of policy prescriptions in the work done by the Framework Convention on Tobacco Control over the last 20 years or so, which has produced a range of prescriptions, policy prescriptions, to both reduce the demand for tobacco, help people to quit, and reduce tobacco supply. So a fantastic, you might say, a vertical approach there to one aspect, which is smoking. A fantastic set of recommendations for countries to adopt there. And it's interesting that there's currently much discussion around the subject of sugar tax and what place that might play. Perhaps in the Q&A afterwards, we come back to that. So, at the global level, fantastic support. At a country level, all around the world, of course, all countries have implemented public health policies and programs which are concerned with many aspects of self-care, addressing health literacy, physical activity, obesity, etc., etc. They tend, though, to be vertical programs rather than more holistic programs looking in the context of the overall self-care story. So they don't tend to be holistic. Austen mentioned already that the importance of the environment, and I'd like now just to say a little bit about the environment, and a bit later on I'll talk about the community environment, the general country environment for self-care. And it's a fact that the natural environment that exists, the built environment, community, work, education and home environments may all present barriers or facilitators to self-care. And urban and rural environments present quite different opportunities and challenges. Cities, of course, where more than half the world's population live, present complex challenges in helping people to maintain healthy lifestyles. The WHO European Healthy Cities Programme, interestingly, identified 12 key health determinants, including access to services, healthy food, open spaces, safe environments, healthy air, physical activity, and communal spaces for social cohesion. And you can see how relevant all of those things are to health, wellness, well-being. There are a lot of healthy city initiatives. These list some of them, and that's again a very important set of drives. ISF itself has been running a World Healthy City Award. This illustrates the award to a couple of Chinese cities that have made good progress in the design of their cities for citizens to engage in healthy behaviours. And I think that the particular angle that we're interested in, of course, is self-care and looking at how urban designers design a city specifically to encourage self-care. So all the other healthy city initiatives are important, but they don't look specifically at the lens of through the lens of self-care. And I put this example up because I think there is an opportunity to design things that promote healthy living, that aren't to do with academic research, but are to do with the promotional healthy lifestyles that one can create to help with that agenda. Other stakeholders, I'll whip through this very quickly. The European Commission's interested in and has a number of programs that they support. Happily talk more about details of those. they tend to focus, these initiatives focus on patients with conditions, minor or chronic conditions, rather than on prevention of health, wellness and well-being, but it's all part of the spectrum, the continuum, as we've heard already. Just to take one government example, the UK government has produced many plans and policy documents over the years, all of which have some element related to self-care. It's not, there's not one big document which says here is the answer to everything, but you can see the trend and the direction of the thinking in these sorts of documents. Let me turn to pick a few examples related to healthcare professionals around the world and self-care. And I start with the physicians because there's some very interesting examples here of work direction by American physicians forming the American College of Lifestyle Medicine, an equivalent European lifestyle medicine organization. And these are professional medical associations for physicians and allied professionals devoted to advancing what they consider to be a new medical speciality called lifestyle medicine. The European Lifestyle Medicine Organization provides leadership in research, prevention, treatment of lifestyle-related diseases through nutrition, physical activity, psychology, and public health. Interesting angle and perception on the situation. In a different example, the Royal College of General Practitioners very recently in the UK proposed that obesity must be recognised as a disease rather than as a lifestyle choice. I think WHO has also looked at this from this perspective. So obesity is not a lifestyle choice, but a disease caused by health inequalities, genetic influences, social factors, etc. And other terms that are used by the medical profession include things like self-management, patients self-manage, patient empowerment, how do we encourage patient empowerment? There's a big person-centered medicine network around the world of doctors interested in person-centeredness of their medical approaches. And I wouldn't wish to criticize this at all. This is all good and positive. But for me, it illustrates the silo nature of one approach. It's trying to medicalize self-care, whereas actually the focus should be on how the individual and empowering them. And of course, they're trying to do that, but it's still a medicalized perspective to our way of thinking, rather than a true personal empowerment approach. Nurses are particularly important because they typically consider the whole person as well as just the condition that the person has. And that's led to some interesting directions in terms of focus on post-operative self-care and the role of home carers. There's one example here at a conference a couple of years ago in Portugal on self-care, accompanied by a book that was published on the dependent person and the family carer. So there's an important drive from the nursing community. And in fact, I think it would be fair to say that the University Nursing Network, the academic network, leads the global academic study of self-care. I would put up Professor Barbara Rigel at the University of Pennsylvania, with whom we were honoured to work, as one of the leaders of the global academic development of self-care. She's focusing particularly on the package that somebody has when they leave hospital and goes home, how to help that person to self-care and the carer perspective there. And in fact, they're launching a new international centre for self-care research, which will be launched in Rome in June of this year. There's a couple of references there. But there's a big challenge, of course, for healthcare systems to adjust, because healthcare systems are generally fully occupied with helping with people with a condition, helping the sick. So the evolution, migration from a sickness model to a wellness model, and from a provider-centric to a person-centric approach is extremely difficult, and that's going to be a huge challenge for the future. And essentially what we're saying, that the doctor or the nurse as expert, there's an opportunity to move from being expert into also being an enabler, a coach, helping people to look after themselves more. And that can be quite a transference. And of course, being a model yourselves, for patients in self-care behaviors. But there are many barriers and obstacles in health systems to self-care. Here are just a few. Disease-specific policies are a problem. Politically, self-care can be seen as a form of rationing. It's not, but it can be seen as a form of rationing. We want you to self-care. Well, that's because you don't want to have to put money into health systems. It's not the case, but that sort of argumentation can be used. There are many reasonable challenges and barriers to the self-care system. Austen has already mentioned the great opportunity for pharmacists and pharmacists to evolve beyond the present responsibilities in many cases into providing screening and monitoring services, medicines management, advice of all sorts, including disease management advice, but advice on healthy lifestyles as well. And in the UK, the healthy living pharmacy movement is, I think, a good example of the opportunity. They have a program which, you see the details here, but on the table there, essentially there's different levels of training of pharmacists to deliver different degrees of support to individuals, and on the y-axis we've got things like smoking, obesity, alcohol, etc., different healthy lifestyle issues address. So that's been an important movement. We've already heard, and Pascal mentioned the number of different technologies that are evolving. I don't know however many 100,000 health apps, but 200,000, 150,000, it's just some staggering number, most of which do the same sort of thing, and there's a lot to be done to see how many of those really help and help in a sustained way for people to keep self-caring. So, but a whole set of different types of technologies are important coming out. And as an example of that, a subset of that, the number of different device measuring accessories, the things that technology can measure on a smart watch, or through intelligent clothing, or through all sorts of different approaches. That list is increasing. What's not happening yet is really tying these things into specifically a self-care package. So again, it's this point, I'm sorry if I repeat it, that there's a wonderful silo of activity going on to do with technology development, but it's not necessarily being designed to support self-care. It's emerging, and in due course it will come. It will, I'm sure, be refined and connect with the self-care agenda. Great silo of activity related to all of the technologies. This much too much detail on the slide, but I just wanted to illustrate the number of different providers of self-care, both products and services. So the thing about self-care is it's not just about what the health system can do for people. It's about a whole range of different other potential providers. Lifestyle gurus or health clubs or gymnasiums are all part of the self-care story. They're important, I think, because they lead to a groundswell of support and encouragement, of push on and raising of the profile of self-care. Whether or not they use the terminology again, it's all part of encouraging healthy lifestyles. This is just a slide to illustrate some of the organizations that have been in touch with ISF and said, can we use your materials? We've got a program involved on International Self-Care Day, or we want to use the 7 pillars concept, can we use it? And we're very supportive of others using it. And to me, it makes the point that you've got clinics, but you've got individual health practitioners, yoga teachers. All of these are part of the story of encouraging healthy lifestyles and self-care. Another important set of stakeholders are international charities that run self-care programs. I've got 2 examples here. One is the White Ribbon Alliance, which is a big US charity involved with maternal, newborn and child care. And they work in some of the least developing countries around the world. And here, the details are rather fuzzy, but they've used the 7 pillars model actually as a framework for the things that should be done under the health literacy heading, the things that should be done under the physical activity heading, etc., for mothers and newborns. So the 7 pillars model isn't just a descriptor of activities, it's also actually quite a useful framework of the things that different groups could do. Similarly, very recently, the Global Alliance on Men's Health has been looking at male self-care, and men tend to be worse at looking after themselves than women. So they've been studying the subject. A report about to appear entitled "Who Self-Care Wins," and have used the 7 pillars as a way of analysing the situation with respect to men and our deficiencies, which are many, to do with self-care. And here's a set of the recommendations from that report. Well, Austin's shown already the slide related to self-care as the basis of healthcare systems. In a sense that I suppose that's a little bit deceptive, because it implies there's a connection, whereas actually self-care is out there in the community. Then you have primary care, secondary care, tertiary care, which are linked together in a different way. But we're allowing that, self-care can be seen as the foundation of healthcare systems. But there is another axis, which I've alluded to already, of course, and that is that the healthy individual in the family situation, the healthy family, healthy communities, and healthy cities. That's a different axis. It's a social compact that is a good way of thinking of self-care. And certainly countries must particularly focus on helping people to stay healthy within the home and community environments. That's a key objective that self-care has. So I'm sort of focusing, you can tell I'm focusing down more and more onto the individual community. First of all, the community level, which is the key unit, I think, for developing much of self-care. And the social networks that people find themselves in, to do with family, friends, other types, and both community engagement, top-down, and community development, bottom-up approaches are going to be really important for the development of self-care at a community level. This has been realised in the UK. Austin's already mentioned the concept of social prescribing, and there are now a move to follow this up in the UK. NHS England plans to recruit more than 1,000 link workers, we call them, able to give people time to talk about what matters to them, to talk about their lives, to talk about the situation, and to support them, find ways of supporting them as an alternative to entering the health system. The objective obviously being to help people, patients, since it's the NHS, they're looking at the patient end of this, but help patients live fitter, healthier lives and combat some of the problems of anxiety, loneliness and depression, which are a big issue in our more modular society in the UK. And I've picked one example of the many experimental programs that are underway at community level. I picked one example, but one could talk a lot about that, because I think this is certainly one way that the researchership agenda should be pushed. It's taking good examples of community success and spreading that across, understanding them, researching them, publishing those results and communicating. This is from a small town called Frome in part of the UK called Somerset, population 26,000. They wanted to reduce hospital emergency admissions by supporting local patients to self-care. So they set up, first of all, mapped the assets they've got in the community and created community connectors and patient support groups to work with people with conditions, sometimes 2 or 3 long-term conditions, and they were able to use that device to reduce the number of emergency admissions to hospital. But there are many examples of this sort of thing, and I think this is certainly one way forward to, if you like, connect the bottom-up agenda with the top-down agenda that we've got going. So that's a very quick run through some different examples of the different activities around the world and the many different silos. And I would like just in the next section briefly to talk about the individual, the self-carer themselves, because actually I've left that to the last. That's the most important person of all in the whole agenda. And I've redrawn that first slide in this way, because essentially the one way to see that is that the self-carer is the person you've got to really think about, and that's, if you like, the demand side of the equation, if you're an economist. Everybody else, all other parties, are suppliers. Supplies, but on the supply side, we can only make a difference to ourselves. Everybody else is a supplier of services that may or may not be taken on. So, to put this equivalent of this slide up, the challenge that everybody has, all the stakeholders, is how do we get away from the vicious circle into a virtuous circle, converting the passive patient into the proactive participant. And let's be clear, self-care is hard. It's hard to do. It's hard to maintain, because self-carers are faced with individual, biological, genetic, psychological, environmental, important situational drivers and barriers. And many preferences and habits programmed from birth are hard to change. And meaningful changes can easily be overwhelmed and undermined in the social environment. So, if we're focusing on the self-carer, there are a few basic points that have to be underlined. And that is, as I've said already, only the individual can self-care. Nobody else can do it for them. And self-care means different things throughout life. There is a sort of self-care throughout the life course. We haven't talked about the life course, but that's a very important different set of things throughout life. What's important from the self-carer's perspective? Their capability, their opportunity, their motivation. Key, absolutely key, their motivation. A holistic perspective, and as Austen's already shown, there are many entry points to self-care. I didn't start looking after myself so much because I used to smoke, and at the age of 39 I stopped smoking and I started to exercise, and I became a convert at that point. So other people will come into self-care through different ways, and you do one thing and then you realise that, well, there's these other elements, and you become more holistic in your approach. What friends, family, community, social media is saying is really important. The environment is important, and fundamentally behaviour is key. So public health policy and research has to recognise the primacy of the importance of the self-carer, the demand side. What about health literacy? Our pillar number 1, really, really important. But health literacy on its own is not sufficient. It's a necessary but not sufficient condition for self-care. Because you might know what we should be doing. I'm sure we all know what we should be doing to self-care. But do we always do it? I certainly don't. I'm promoting self-care. So It's a necessary but not sufficient condition. Self-awareness and a sense of agency and maintained agency over time is absolutely key. And that's why I think another of the really important silos, and it is a silo, is to do with the academic health psychologists, the behavioral economists who are working in areas such as, they call things like nudges, carrots and sticks, how you change behaviors a little bit at a time, and looking at different types of intervention mechanism that are listed there, education, persuasion, etc., etc. So a fantastic set of works being done there that needs to be connected into all the other agendas. Because at the end of the day, fundamentally, everybody's motivation to self-care is different. You might want to stay healthy, you might want to avoid the dementia that you saw your parents having. My excuse for doing a half marathon a couple of years ago was that I have to stand up and talk about self-care, so I've kind of got to show that it's possible that it does work. Quite why somebody would want to run a marathon dressed as a chicken, I don't know what their motivation is, but good for them. The other really big thing that we haven't touched on this at all, so forgive me if I just take a minute to underline the importance of this slide. In the Alma Ata Declaration, there's reference to rights to medicine and the rights to healthcare. There's also reference to rights and responsibilities. We all have responsibilities as well as rights. Rights in health are balanced by responsibilities. We in fact all have a moral responsibility to look after ourselves, to self-care, to the best of our ability. And that responsibility is based on a couple of factors. Firstly, of course, is the self-carer is the primary beneficiary of self-care, and that's really important, isn't it? But the moral responsibility is also based on responsibilities to others, particularly other users of scarce healthcare resources. Healthcare resources will always be scarce and costly, so there is a responsibility to use those resources wisely. And by extension, future generations. You have a responsibility to future generations, not least one's own children. So the challenge here, and this is essentially a political challenge, and how individual countries address this particular challenge, how they establish and agree collectively the societal balance between rights to health and healthcare and versus the responsibilities that we all have to our own health and the consequences of poor lifestyle choices is going to be the really big issue going forwards. And I have to say, this is an area that tends to get ducked because of it's a very tricky and hot topic. But herein lies one of the nuts of why self-care isn't advancing, because governments aren't in a position and don't wish to lay down the law in a way that sometimes might be necessary. So, conclusions from the presentation. First of all, strong foundations exist. All countries have implemented public health policies and programs concerned with many aspects of self-care. But all countries are a long way from implementing coherent and coordinated prescriptions designed to promote individual and population self-care capabilities, shift professional practices, or reorient healthcare systems towards prevention. And I think we can see what some of the reasons why that is, or where it is at the moment. So we're some way from real transformation everywhere. So what's the way forward? Well, self-care, as we've seen, has many stakeholders. So important in ways forward are communications, networking, and a common understanding of self-care are really critical things going forwards. In terms of policy pointers, it should be better understood that we are all talking about the same thing. Self-care is, as described, that the language may be different, the positioning may be different, but actually it's one thing. It's about helping individuals, a real focus on the self-care, the unifying factor of all the stakeholders, I'd say. I think the concept of health in all policies is a brilliant and helpful concept, and as Austen's already indicated, could be self-care in all policies. It's also, I think, clear now from these presentations that we haven't got a simple or single toolkit of programs or policies available. There are many policies, many programs available, not one set that you can take out of the book and apply. And realistically, I think the way forwards is going to be evolution, not revolution, incremental rather than radical change going forwards. Many different policy opportunities. Now I think you can see if you look at any area of public policy, it has a self-care relevance to it. Every way forwards. Lastly, and very briefly, possible way forwards in Malaysia, indeed in potentially any other country. Let's talk about Malaysia. Float for discussion the idea that it would be helpful to have the self-care narrative for Malaysia. I'll say a bit more about that in a minute. A forum for all stakeholders. Perhaps you have that already. Clearly, communications and events related to self-care and a research agenda, which we touched on already. And the proposition is that a self-care narrative for Malaysia would be useful. The narrative which would briefly summarize your unique situation. You have a unique situation in the profile, for example, of smoking and obesity, low alcohol problem, relatively speaking, across the population. You have a unique profile, health profile. So the way that self-care could fit and should fit is different in Malaysia to elsewhere. And I think all stakeholders in Malaysia would benefit from a common understanding of self-care, starting with a clear articulation of its nature and purpose, status report or narrative for Malaysia. And clearly, while self-care should be making a much greater contribution to health today, as we've seen, for the reasons we've seen, the case still needs to be made, explained, shared, agreed, developed. A huge opportunity there. And the developing narrative can provide the basis for research and policy development and for communications. And we had the pleasure of visiting the SIACO group down in Segamat yesterday. Very interesting, a wonderful resource, a really interesting opportunity to look at the lives of an important population of people there through the self-care lens, we might say. So we've got a good basis there for putting that into a self-care narrative. And these things exist. This is the self-care narrative that was produced, published last year, State of Self-Care in Australia. The Australian Health Policy Collaboration put this together for Australia. I think that's the model of the sort of thing that then puts everybody on the same page and can take forwards. Second of the possible areas is establishing a national platform for involvement and networking of key stakeholders going forwards. What would the focus be? That's for discussion, of course, agreement, but it might be information sharing, best practice promotion, encouraging these local initiatives. That's the key element of the UK Self-Care Forum, which is a national forum. What they do particularly, they have a number of events, Self-Care Day, Self-Care Week, but they also encourage these community-level programs and the sharing of information about community-level programs. Events and communication, really important to raise the profile of self-care, and particularly events involving global self-care groups can be a very powerful illustration of the opportunity for self-care. The International Self-Care Foundation has, for a number of years, been running and encouraging people to do something on International Self-Care Day on July 24th. It's on 4th of July, that's 7/24, because the benefits of self-care are experienced 7 days a week, 24 hours a day. So it's a memorable for that reason. And here is some illustrations of activities run on International Self-Care Day each year from around the world. You'll recognize Pierre Trudeau from Canada, the Canadian PM, who specifically on IST in 2016 wrote a letter to all citizens on International Self-Care Day, in the past, we've had a US Senate resolution for 24/7 recognizing that as an official day. We might recognize Jackie Chan as the previous ambassador for ISD. And listing here are some of the countries that have run programs related to self-care on that day. And I'd love to be able to add Malaysia to that. And you can do whatever you want that pushes the agenda for self-care forwards. And my last slide really just refers to different sorts of research that then can back up what's needed. Community-focused research, I've talked about a lot. The importance for people-focused studies, behavioural studies, inducements, barriers, and obstacles. And you'll see the point now of listing stakeholder roles and how the stakeholders fit together. And all of this sort of research then should lead to policy development and recommendations. And we have, the ISF has a companion journal, the Self-Care Journal, and we're very keen and happy to publish papers, case studies, whatever, on aspects of self-care. So that's a very quick whip around self-care around the world, and I thank you very much for your attention.
However, one of the things that you showed us just now is about the self-care product suppliers, right? And you included organic food supplier as well as yoga instructors and so on. Now, how do we separate the snake oil salesman from proper evidence-based healthcare interventions that are self-care oriented?
Yes, I think that's a very important point. I must admit that at this stage of the development of self-care, we've had an approach that is more about encouraging and raising the profile. But you're right. This is why Pillar 7 is the responsible use of products and services. And the word responsible is really important in this context because one doesn't want to encourage that. One element is of course proper research of some of the interventions and developing the evidence base. So one person's acupuncture is another person's stakeholder. So I don't want to be drawn into what are valid interventions and what are not. There's a need for research there. But in the final analysis, yes, there's an important role for regulation. The government has a role to regulate medicines, just as medicines are heavily and highly regulated. That's an appropriate position for government to wade in there. But you can see my theme is more to sort of encourage and raise the profile of self-care, and we get asked to encourage practitioners, and sometimes we think, well, gosh, but it's their energy and enthusiasm. We know they mean well, even if we don't think that's a particularly wonderful thing to be doing, but we know they mean well. So it can be a challenge.
Yes. Here. Thank you very much. Those were very insightful and comprehensive presentations. I'm Michelle Rim. I work here at UNIIGH, and I fall in your box of health economists, so I'm going to ask a question about costs and financing. You both made the argument that self-care can, has the potential to reduce costs for the health system, but there is a risk that's coming out. I think that there it might transfer or shift costs or the financial burden onto users. So having a healthy diet might cost more than an unhealthy diet, or gym membership, or specific devices or interventions might end up being, falling on the wallet of a user. So I wonder if you could reflect on that and if there's any evidence that you can point towards, and specifically how to ensure that it does not exacerbate inequities.
Can I kick off? I'm sure Austen would like to add to that. I think there's several points to be made here, and it's a really important area, and more strength to your arm to be studying this area, because I think it's key. I'm fascinated by the fact that a study a few years ago showed that the cheapest person to the health system is the smoker, the heavy smoker, because they die. So in pure health economic terms, forgive me, the cheapest person is the smoker. What we're really trying to achieve is to help people to have long, healthy lives, a long health span, and then drop dead suddenly, if I can put it that way. The Japanese have a term for it, pin karori, live long and die suddenly. And that's, if you like, the economic model that we like. So to address the point that the cheapest person to the health system is the smoker, what would be helpful from a health economic analysis point of view is to look at and this hasn't been done to the best of my knowledge, none elements of it, is to look at the all the economic elements to do with a person living long and dying suddenly at an older age. That is to say, their economic productivity at work, the taxes they pay, all the different elements, how they're able to better support their families, their quality of life, how you bring that in. I don't know, I'm not a health economist. So I think there is a bigger picture to be analysed and understood to do with health economics that I wish would be a greater focus to address this point about, because the cheapest is the smoker. The second cheapest person are people who are heavily obese, because they then get a whole set of other conditions and tend to die earlier. So this is the bigger picture, if you like. You mentioned a specific example, and I think that's sort of a microeconomic analysis, if you like, rather than macroeconomic. I think it's really interesting. There's a real problem with junk food consumption in the UK at the moment, because junk food is cheap, it's easily available, and it doesn't take any time to prepare. The reality, though, is that you can go to a local shop and you can get cheap ingredients, but you have to cook it, you have to prepare it. There's a time element, and how you trade those two things off. So we've got TV programs at the moment in the UK with titles like "Live Well for Less," where it follows people who tend to live on junk food. They go to the burger bar every day. And nothing wrong with the burger, but not every day, of course. They will have junk food every day, and it helps them look at other ways of surviving. So you're right about the point, and it's a very important point, but there are ways of addressing that and helping people to eat more healthily without it being hugely costly.
That's a very comprehensive. Fitness, technically speaking, is a very complex analysis. And do that for self-care is very complex, and that's why our mission to make the absolute case for self-care will take some time, because cost effectiveness and cost savings and etc. are different things. I think also to think about the at scale, the culture element here, for example, in the UK, so we have allotments where people are encouraged to grow their own organic food, not because it's cheaper or they don't want to pay for it in the market, it's because it's something to do in the community that them and their neighbors can go. This is a limited resource, especially in cities and where we live. So I think this is where policies can come in, and there was mention, I think, at Wilton Park or elsewhere, where, for example, women in England have complained that because the menstrual cycle would cost them so much money in terms of the materials they have to get. Can the government not do something about that? This is self-care. They need to be fresh, and they need to go about their business and do work. So these are policy instruments that can be looked at another level. But it's a very big argument, and I think if manufacturers think or are asked to think differently, then that will make a huge difference in terms of demand and supply.
Can I, before the next question, unless it's about economics as well, can I push you a little bit? And you kind of went very quickly over what you thought were the harder questions, but you didn't give enough time to, which is then actually advancing the argument on the moral obligations of people, which also has, from my perspective, a health systems cost. Because essentially what you were talking about was a balancing of the possible abrogation of government responsibility to provide health against people's responsibility to remain healthy, which then becomes very much a political issue. Not, I guess, universally acceptable. It is a highly political question. How do you think the literature has dealt with it, or the evidence, the current evidence has dealt with it, or how would you respond to that? That essentially, it's not a health services are not a zero-sum game. So, but you're arguing as if it is, as if I access care, I'm taking it away from somebody else because I'm not looking after myself. That's a major argument.
But I think I would argue that there's much as the objective is universal health care. I mean, we would accept that, but that's always going to be limited. The governments will, whether they put in 10% of GDP or 15% or whatever it is, it's a huge cost. So there is always going to be a limited supply, and we are faced with an enormous increase, as you know better than I do, of incidents of NCDs, people aging, etc. So the demand side is increasing. I suppose I was going a little bit strong on that because it's slightly frustrating to not have this area of discussion out in the open and properly aired. So I don't want to push it too far, but I do believe that we don't currently get the balance right, and that politicians react to challenges, and the sort of challenges they get are around it's a nanny state. You have no, it's my right to do what I want to do, in effect. And I think that needs pushing back on. Is it your right to lead an unhealthy life and require huge costs, huge financial support through a health system? So I think these discussions haven't been had. And really my point was to push and see what pushback we got. So people complain about the nanny state, and that's an interesting thing to discuss. It's a rich discussion that needs to be had.
And if I may, David, we had an example in the UK recently where there was in the newspapers the idea that people who want cabbage for heart surgery and who are known smokers should not be first on the list because there's normally a bit of a waiting list. And that caused a huge public outcry. And I think this is a political exercise. I think one of the members of Parliament mentioned this, and that was a discourse. So, and one of David's slides that I was showing in my talk was about the beneficiary of self-care. And one of the examples was the healthcare professionals can focus more of their resources on those people who need them. It doesn't mean to say that they couldn't treat people who weren't taking care of themselves, but the idea is the beneficiary here, there'll be more resources for people who really need the support for interventions like cancer and more complicated conditions. So this is a politically heavy topic, and I think maybe in future we can revisit separately. And one thing we discussed, David and I, was politicians will never tell you that the welfare state created after the Second World War is no longer sustainable. Post-Second World War, there was devastation in England and elsewhere, and we needed the welfare state to support housing, etc. And I think that it was imminently conflicts the 21st century thinking. So these are the very fine lines, but that's a lamentation, I think.
I mean, the other element, just another element of what is a rich discussion is that there's some evidence that the better the health system, the more the dependency you see on the health system and the less that people try to look after themselves. And that is a danger. If you want a good health system, of course you do, no one argues that. But we see that in the UK to a degree that people's attitude is, I pay my taxes, if I get sick I go to the doctor, it's his job to fix me. That would contrast with if you take a country where the health systems are less adequate. And I do a lot of work in China. China's an interesting example in all sorts of ways. Historically, their health system hasn't been very good, of course. And what you see there is a different philosophy towards looking after themselves, a more holistic philosophy, looking at the different elements, the use of traditional medicines, etc. And now, I'm not saying that's good because it's been forced by the lack of proper health infrastructure. I'm not trying to justify that at all, but you see a different philosophy operating there that we could probably learn a lot from in the West in terms of looking after ourselves.
I would say that's an interesting, for the researchers looking for topics, that's an interesting one to look at. I can take 1, 2, 3, 4. Do you mind if we take the questions together and then you can respond to them because we're running out of time? Yes.
Hi, my name is Annie. So I'm interested with self-care and mental health domain, and I would like if Dr. Austen, you could share a little bit more of what has been done, or like the research that has been done for self-care programs in the mental health domain, and perhaps share an example of a successful intervention in a university setting.
Okay, that's a mental health one. Somebody else?
Okay.
Hi, my name is Ida. I'm from the Hospital Chancellor Toolkit. Most self-care concepts is frequently talked about in terms of the primary prevention and secondary prevention. So I'd like to know your thoughts on the sustainability of this concept, the self-care concept, in the long-term prevention, ideas like more into tertiary prevention sort of concept.
Lavanya, I think.
Hi, I'm Lavanya from IIGH. Thank you very much for very interesting presentations. My question is a little bit of an extension from Michelle's and Pascal's as well. So we talked about very positive words, patient activation, empowerment, but also on the flip side, there's also the very negative possibility of the narrative being used in a negative way that disadvantages the self-care, the person. So going regressively into this notion that a person is sick because of things that they did or didn't do, and they're to blame. So how do we sort of balance that narrative? What are precautionary measures that could be taken at a policy level, at community level, in the workplace? Thank you.
Yes.
Hi, I'm Dr. Irwin. I'm a pharmacist. So with regards to about the community pharmacy, I agree with that there's a lot of activities, particularly in community pharmacy, for self-care and also for smoking cessation and lifestyle modifications. Now my question is, in terms of the verge of migration and in terms of refugees, what is your opinion, or what would be the stakeholders' responsibilities in terms of self-care, and how can they actually benefit? Or maybe there's a program that you can recommend in terms of migration and of course for refugees.
Was there one more on that side? Anyone else with a burning question? No? Okay. Over to you. You've got mental health, longer-term prevention, rebalancing the narrative, and mobile populations.
Shall I take 1 and 4? Yes. So on that first question, Anis, thank you. I think in the Wilton Park dialogue, incidentally, Public Health England have announced that there is a self-care for mental health program being launched in April. Now this is for the UK, and there will be other examples elsewhere. In the hospital or university or the workplace health promotion setting, there's occupational health, of course, which for a long time has been doing work in musculoskeletal to try and and other work to try and reduce absenteeism, presenteeism. But since about 5 or 10 years ago, there's been a huge drive in England and elsewhere to reduce stigma for mental health. So this in itself is a very important thing for self-care, because then you have more awareness about mental health conditions, and if you are tending to depression, you may pick up with your colleagues and friends, etc. And by the way, incidentally, Prince Harry admitted depression recently, and since he did this, the government was very interested to do that. And actually, that was one of our reasons for ensuring we have a self-care and mental health theme at SCARU. I mean, this was important anyway, but it all starts in the mind. It talks to activation, it talks to the willingness to survive, it talks to willingness to social isolation is a very important thing. It's not a mental health condition, it's more of a situation. So I hope that briefly answers your question, and so as not take too much of your time, maybe we can discuss separately. But that's some of the work being done. In relation to the refugee crisis, for example, I'm from Lebanon, so we have a lot of Syrians, and they're welcome because we fled to Syria when we had the war, and this is a contemporary issue globally. The role of the pharmacist now, this pharmacist could be, obviously they need to be well trained. They're dealing with the mental health aspect of that. That's why I thought wonderful, relevant in crisis situations with probably very limited resources. And no matter what the pharmacist would do, the problem wouldn't go away. I mean, they may treat the infection with antibiotics, but there will be other issues. So here, the role of the pharmacist then is expanded. We have examples where you have a hub and spoke model. It could be a pharmacist on wheels. It could be a traveling caravan with point of care testing. Now, what happens when you detect undiagnosed diabetes or atrial defibrillation? There are pathways. Provided resources available, you can actually direct resources and help people to hopefully avoid the consequences. So again, this is a summary of how healthy lifestyle interventions and lifestyle over pills can be used. We did a small project with the Netherlands on how senior citizens, for example, can be helped to stay off medication for 10 common conditions and everyday conditions and ailments, including insomnia, diabetes. And as David showed in one of his slides, it was made mostly exercise and healthy eating. But of course, you can't tell the refugee that. So I'm sorry if this answers your question directly or comprehensively, but the role of the pharmacist is important. Increase their span and scope of their work. Allow them to prescribe medicines, ideally with the support of point-of-care testing to detect infection or otherwise, and that will go a very long way.
Just a quick addition to that, because I've been involved in recent discussions where the other self-care technology is the linkage of actual health records for chronic illness, because when you're talking about mobile populations, they need to have access to their own health data to be able to act on it, and also to be able to present it in different health services. We actually did part of the guidelines development on. Yes.
Does it mean that through your experience, the catalyst which shift the behavior of either regulators, physicians, and the patients, public, from depending on the primary, secondary, tertiary to self-care is health technologies? Is it?
That is an enabler. It's not the answer, but it is an enabler.
But would the presenters be able to share across countries what are the maybe common catalysts for the change?
Okay, that's to add to your question. Thank you. So David, you could pick that up with everything else now.
Okay, well, I'll pick up what I can remember. I'd like to just come back on the point that made by the refugees, because it stimulates a different thought in mind. I talked a lot about the importance of developing the narrative, and in a book, a written down thing is important, but the societal, the country narrative that relates to self-care is really important. Within that, because every country is different, there's an interesting part to be done around what is self-care in resource-poor situations. Now, Malaysia is a middle-income country or not a poor country, but we don't know, and we don't have enough information about what does self-care mean to somebody who doesn't have access to a lot of things. So that does need research and examples and so on and so forth. Well, nobody would wish to be in a refugee camp, of course, but the understanding of how you can look after yourself, faced with the situation you're in, however poor it is an important thing that we need to understand better. In terms of the point about the negatives of self-care, how perhaps society then puts pressure on people negatively because they can't or won't or whatever self-care, if I understood, I'm putting that crudely. I think we're seeing it already, and this is a debate that's happening in the UK, to take an example, where people who are too overweight, too obese for a particular operation are required to reduce their weight, and the argument there is your chances of survival of this operation are better if you're reduced in weight. You're seeing insurance companies setting different insurance levels according to whether you smoke or not, what your body mass index is, etc. So I think we're seeing that sort of thing coming, and that's going to be part of the national dialogue that should be had as to what society as a whole wants to have, because we don't want an uncaring society. On the other hand, we do want a society that encourages healthy lifestyles. At the end of the day, we're talking about encouraging people to live long, healthy, active lives. And quite where the level then gets pitched within a country will depend on the cultural characteristics and many other things within the country. So I recognise the danger, but it's not an argument for not encouraging healthy lifestyles. And I'm sorry, can you repeat
It's about the sustainability of self-care in the long-term prevention, for example, in the tertiary prevention. Because, to see whether, because I'm particularly looking at long-term stroke care.
Yeah.
So I find that, they do have a little bit of, ideas about their self-care, but it seems not to be able to be sustained for a very long time. So what's your opinion on that?
Yes, I remember talking to Barbara Rigel, who leads on from the academic nursing perspective, and I said, well, surely people who had a stroke or whatever are really good at looking after themselves and watching out for signs. And she said, actually, no, they're not. They don't take this on board, and they don't do what they should be doing. And this is a real challenge. So this was a shock and a surprise to me. And I'm afraid I can't give you the answer to it, but it brings us back to this fundamental question of understanding people's behaviours better, and that's a really important silo of activity that needs to be done to really get to what people's motivations are. Because it's fine addressing their capabilities through health literacy, it's fine addressing their opportunities through the environment they're in, but at the end of the day it comes down to people's motivations, and we don't know enough about motivation.
Okay, it is now 1:45. I can hear tummy rumblings, literally. I think this links very nicely for those who were here for the previous Malaysian Global Health Consortium meeting as well. Provides us quite a bit to think about in terms of developing research agendas and so on. Really rich food for thought. Wonderful turn up from a range of stakeholders and important stakeholders from across Malaysia. So thank you all very much for coming. Give yourselves a round of applause. And then, as is traditional, thank you, David. Thank you, Austen.
Thank you, Pascal.
And please thank our presenters.